Welcome to Iswam Virtual 2021.
Honorable Minister of Health of Republic Indonesia, Honorable Minister of Tourism of Republic Indonesia, Honorable Chairman of Indonesian Medical Association and all the boards of Indonesian Medical Association, Honorable Head of Berdaweri, all speakers, all attendees, all partners, all exhibitors of Iswam 11 Iswam 2021. As CEO of Iswam, I would like to welcome all of you to join once again 11 Iswam 2021. All of us know right now is the pandemic situation, and of course, Iswam will be transformed into totally virtual, which is the first Iswam virtually. But I would like to ensure all of you that we are working very hard to resemble as much as possible as face-to-face conference. So there will be 24 sessions of scientific event with 51 speakers from 70 countries. And as usual, Iswam will always has exhibition. So please join us. Please enjoy this 11 Iswam. And we hope, we pray together that we can solve all of the nation pandemic situation as soon as possible, and see you at 12 Iswam in December 21st. Enjoy.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Happy morning. Greetings of us all. First, Alhamdulillah, thanksgiving to the presence of Allah subhanahu wa ta'ala for His grace and protection. Then event in this morning can go on according to the plan. Dear Dr. Teguh Tanuwijaya, President, and the entire committee of the International Seminar and Workshop in Aesthetic Medicine, Iswam 2021. Dear speakers and participants of Iswam 2021, both from abroad or inside, which I respect. The COVID-19 pandemic, handing throughout the world since December 2019, has not ended. Even experiencing new wave in many countries, including China. The COVID-19 pandemic should also be looked as a strengthened religion from the Almighty to human people for very constructive lifestyle behavior, for unlimited exploitation of natural, social, and economic resources. Pandemic forces us to work from home, learn from home, and pray from home. Science and technology, especially in the field of medicine, including aesthetic medicine, developed with very fast, uninterrupted by pandemic. Therefore, scientific events should be implemented as a means for updating that development. Scientific events must be adjusted to the new normal of COVID-19. Pandemic also created thought of having Iswam, which is usually handled in large building, attended by thousands of people for 3 concerning days. In 2021, Iswam's implementation must be changed. Iswam is executed virtually during a long period. Start from January 5 today to the 30, 2021. Although I assure that the quality of Iswam 2021 is not lower than the previous Iswams. Even if reviewed from the event materials and the speakers, I see that scientifically Iswam 2021 has better quality than ever Iswams. There is the law of God applied. In one party, pandemic COVID-19 is considered as a disaster. But God always considers with hikmah, which is useful for human life. With virtual implementation, Iswam 2021 participants can attend the scientific event from its home or workplace without having to expense transport and accommodation fees, which is used to be more expensive than Iswam registration fee. Speakers from various places, especially from abroad, don't need to expand a long time to come to Indonesia or Jakarta, only to talk a few minutes. For that, as the president of Perdaweri, I say so much thanks to the Iswam 2021, which most of Perdaweri members can ask for the science and obtain update information. Before ending this brief speech, permit me to say thanks to all the speakers, especially to overseas speakers who have been able to attend and share their knowledge and experiences with Iswam 2021 participants. I also say congratulations to all 2021 Iswam participants. Hope to get the best benefit from Iswam 2021. Especially thanks to all committee for hard and intelligent work so that Iswam's event can be open in this morning. And inshallah, I am sure will go on successfully until January 30. Wassalamu alaikum warahmatullahi wabarakatuh.
Masuk, dokter.
Good morning, everybody. Hello, everyone. It is my pleasure to welcome you all to Virtual Iswam 2021. Thank you for being here with us today in Iswam. Iswam is the international seminar and workshop in anti-aging and aesthetic medicine hosted by Perdaweri. Iswam has been held in Indonesia for 10 years, and now this is the 11th Iswam, because we're still in pandemic situation, so this time we present Iswam in virtual. Before we start, we would like to say thank you very much to Professor Abdul Razak Tahak for a welcoming speech and for fully support to this Iswam virtual. Perdaweri is the Indonesian Association of Doctors in Anti-Aging, Wellness, Aesthetic, and Regenerative Indonesia. We also would like to say thank you very much for the support of IDI, that is the Indonesian Association of Doctors in Indonesia, for all guidance and all support for the virtual ISWAM until today. Perdaweri has presented several series of webinars during the pandemic in order to give knowledge for doctors to keep learning during this pandemic situation. And before we start, I would like to apologize if there is any inconvenience during this event. We're preparing very well to give you the best, so you all doctors may learn about aesthetic, anti-aging, regenerative, and wellness. Okay, now we hope all speakers and participants enjoy the ISWAM 2021 so we can learn and get more knowledge. Okay, I am Dr. Santi Sadikin, will be the chairman for today. It is my pleasure to be the chairman for today's session. Okay, so now we will come to the first session, that is the session of ethico-medical legal. As we know, as doctors, we should understand about legal aspect in medical practice. Patient safety is a must. So we would like Professor Abdul Razak Taha to become the speaker of this session of medical ethical legal. So let's welcome Professor Acha. Good morning, Professor Acha. Professor
Good
Abdul
morning,
Razak
Dr.
Taha.
Good morning,
Okay.
Dr. Santi Sadikin.
Yes, nice meeting you again, Professor Abdul Razak Taha. Hope everything is well there. How are you?
Fine, thank you. Fine,
Yes,
thank you.
okay. So it's an honor to have you here, Professor Abdul Razak Taha, and you may share about patient safety to all of the participants, doctor here. Before you give your presentations, may I read your curriculum vitae first? Okay, so this is the curriculum vitae of Professor Dr. Abdul Razak Taha, Master of Science, specialized in nutritionist from Indonesia. Education, 1977 from Hasanuddin University, Doctorandus Medicine. 1982, Hasanuddin University for medical degree. 1986, Siameo Tropmed, PHUI, Master of Science in Applied Nutrition. 1995, Hasanuddin University Professor for Public Health. And now as a lecturer at the Faculty of Public Health, Hasanuddin University. Okay, now it's time for Professor Acha to give presentations about patient safety. The time is yours, Professor Acha.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Good morning. Greetings to all of us. Thanks, Dr. Santi Sadikin, for your time. I will talk on the topic of patient safety. Due to limited time, I will only present the general principle of patient safety. The objective of this topic is understand the science of patient safety and its role in minimizing adverse event and their effect and maximizing recovery of affected patients. There are various definitions regarding patient safety, among others. Patient safety is this discipline in the health sector in which the method of safety sciences is applied in order to achieve a credible health care system. Emmanuel said that the patient safety is an attribute in the healthcare system that is intended to minimize the incidence and adverse effect for patients and maximize recovery from medical accidents. This definition divides the health system into four main domains. First, those who work in health services. Second, those who receive health services or have a share in the availability of health services. Third, system infrastructure for therapeutic intervention. And the last method for continuous feedback and improvement. With a system, the history of patient safety starts from the blame culture in health services. Next question is, why do we blame? The answer for this question begins with an individual approach, looking for who is wrong, who is responsible. From various experiences, it is realized that this approach does not solve the problem. It even creates a new problem. So, since then, a new approach, namely the system approach, has been implemented. With the system approach, the patient safety culture is interpreted as a culture in which all medical workers, including frontline staff, physicians, and administrators, accept responsibility for the safety of themselves, their colleagues, patients, and visitors. A culture that puts safety above financial and operational objectives. A culture that encourages and rewards identification, communication, and resolution of security issues. A culture that provides organizational learning organization from medical accident. A culture that provides the right resources, structures, and accountability to maintain an effective security system. Reasons explain that only a system approach, as opposed to individual blaming approach, will create a safer health culture because it is easier to change the condition people work for than it is to change human behavior. When systems fail, the question to ask is why it failed rather than question who caused it fail. For example, we decide a protection failed. Reason explain schematically depicted through the sweet. He said that the name is sweet cheese. The sweet cheese diagram show that error in one layer of organization are usually insufficient to cause an accident. Adverse outcome usually occur when a number of errors occur at a different layer. Rule violation, inadequate resources, inadequate oversight, inadequate experience, and then increase the risk so that there is a chance for an unwanted accident. The implementation of the Swiss cheese diagram or system approach is to find the root cause of an accident, often referred to as why approach. The following event is a simple example of the why approach. The nurse gave the wrong treatment. Why? Because he misunderstood the doctor's instruction. Why he misunderstood? Because the doctor was tired and it happened in the middle of night that the nurse was afraid to repeat to ask the doctor. Why is he afraid? Because the nurse knows that the doctor will get angry if they repeat the question. Why he get angry? Because the doctor was tired after operating for 16 hours. It must be answered solely. Why doctor is tired? Maybe because doctor have too many work in many hospital. Continue the why, until you find the root cause of the problem. It must be answered thoroughly. So what must be done is to address the root cause of the problem. Human factors are important factors of patient safety. Why is it important? Human factor problems are a major contributor to medical errors in healthcare. In healthcare and other high-risk industry, such as aviation industry, the human factor can have serious and sometimes fatal consequences. However, healthcare system can be made safer by recognizing the potential error and by developing systems and strategies for learning from mistakes that ultimately minimize their occurrence and effect. Is it possible to manage the human factors? Yes. Human factor management involves applying a proactive technique aimed at minimizing and learning from mistakes. A work that encourages reporting of medical errors in healthcare enable the healthcare system and patient safety to improve. How is human factor management to achieve patient safety? They are the way in medical practice. Apply the human factor framework in medical services. Avoid depending on memory. Viewing pictures or diagram can reduce the burden of working memory. So you can focus on the tasks protocol based on very important proof. Make everything invisible. Facing new and sophisticated equipment, characteristics of aesthetical practice, it is helpful to use pictures and information about the steps for turning the applicants on and off and reading the display. Reviewing and simplifying the process. Simple is better. Some healthcare tasks have become so complex with the potential for error. Standardized procedures and process. Standardized procedure and process can greatly help medical staff reduce reliance on memory, which can increase efficiency and save time. Routinely use checklists. WHO stated that the use of checklists is common in many health service activity. Reducing dependence on precaution. In repetitive, routine, and lengthy activities, humans tend to be less alert, especially when tired, so they fail to focus at some point. What we have discussed in the system thinking approach is called structure influence behavior. Structure influence behavior is explained by Peter Senge. You know that Peter Senge is the author of the monumental book of the fifth discipline. When placed in the same, Peter Senge said that, when placed in the same system, everyone, although different, tends to produce similar results. I want to give a sample of Indonesian people. An Indonesian who liked to violate the traffic rules in Indonesia, when he arrived in Singapore, immediately turns into a person who is very obedient to traffic rules. Once he back in Indonesia, back again for the pension for breaking these traffic rules. This is the mean of structures influence behavior. To build a patient safety atmosphere with a system approach, team learning is needed. Why team learning is important? Team learning increasing complexity of medical incident and specialization of care. That's why team learning is needed. Increased comorbidity, increased incidence of chronic disease, limited human resources, limited time, limited facility, limited costs, etc. In health team characteristic, team learning means that know each other roles on the team and interact with each other to reaching common goals. Decision making, process specific knowledge and skill and function in high workload condition. It acts as a collective unit, the interdependence of task performance by team members. What should be done based on the concept of structure, influence, behavior? Improve of workplace design and equipment to suit human capability and limitation. Makes it easier for workers to get work done in the right way. Reduce the chance of error occurring. Good human factor design in healthcare accommodate a whole range of work. Not only calm, rest for experienced doctor, but also for inexperienced healthcare workers who may be stressed, tired, and hurried. What are the factors that can increase the risk of error? In the situational factor, you will see no experience, lack of time, inadequate checking, bad procedure, insufficient information. An individual factor aspect, limited memory capacity, fatigue, stress, hunger, and pain. Individual factors commonly abbreviated HART, hungry, angry, late, or tired. Am I safe for work today? To check your readiness, use performance shaping checklist. I am safe. Illness, a medication, a stress, a alcohol, a fatigue, a emotion. I am safe. Doctors who work in the field of aesthetic medicine generally work in clinics. Why clinical risks are relevant to patient safety? Clinical risk management is specifically concerned with improving the quality and safety of healthcare services by identifying the circumstances and opportunities that place patients at risk of harm and acting to prevent or control those risks. This is a four-step process for managing clinical risk. First, identify the risk. Second, assess the frequency and severity of the risk. Third, reduce or eliminate the risk. And the fourth, the cause of the risk. Another important factor to pay attention is complaints. Why is it important to pay attention to complaints? Because complaints help in maintaining standards. Complaints reduce the frequency of litigation. Complaints help maintain confidence in the profession. Complaint encourage self-assessment. Complaint protect the public. Patient complaint need to be heard because patients have an important role to play in reducing risk. Patients want to be included in their healthcare, but it depends on the job. Patients feel comfortable, 85%, asking about the goal of treatment, but nearly half, 45%, felt very uncomfortable asking health workers if they had what they had. Below is the Harvard framework for good communication with patient. Preparation, start and conversation, present facts, listen actively, ad, admit what you have heard, respond to any questions and the conversation, and don't forget documentation. Robert Buckland created a formula for communicating with patients which he named spikes. Spikes sharpen your listening skill. Pay attention to patient. Invite the patient to discuss details. Know the facts. Explore emotion and deliver empathy. Strategize next step with patient or family. How to act to minimize the spread of infection. Before contact with each patient, clean hand before touching the patient. Clean hand before aseptic assignment. After contact with each patient, clean hand if there is a risk of exposure to body fluids. Clean hand after patient contact. Clean hand after contact with the patient environment. How can drug administration strong? Safety in terms of drug administration makes too often a cure. How can drug administration wrong? The wrong patient, wrong route, bad time, wrong dose, wrong medicine, negligence, failure to manage, insufficient documentation. For that, it is necessary to pay attention to 5 right. Right cure, right route, right on time, right doses, right patient, and customize your prescription for each patient. Consider allergy, comorbidity, especially liver and kidney disorders, other drugs, pregnancy and breastfeeding, and posture for the patient. Thank you very much.
Okay, thank you very much, Professor Abdul Razak Taha, for the explanation about patient safety. We all doctors have to notice because during the pandemic, we have to notice many things that when we doing practice to patients. For this session of Ethical Medical Legal, there will be no question and answer for our audience. So once again, we would like to say thank you to Professor Abdul Razak Taha. And then we shall continue with the next speaker, still in ethical medical legal. The next speaker will be Professor Dr. Purnawan Junadi, MPH, PhD. Okay, let's welcome Professor Dr. Purnawan Junadi. Hello, good morning, Professor Purnawan. Are you with me? Okay, Professor Purnawan. Yeah, can you hear us clearly? Okay, I see that you still maybe in hospital. Yeah, thank you for being here with us, Professor Purnawan, to share knowledge. And for today's session, Professor Purnawan will talk about aesthetic fight COVID-19. This is a very interesting topic because everybody are waiting for this, Professor Purnawan. Before you start the presentation, may I read first your curriculum vitae? Professor Purnawan Professor Dr. Purnawan Junadi, PhD from Indonesia, Education, 1972-1978 from Faculty of Medicine, University of Indonesia, 1982 until 1983, School of Public Health, University of Michigan, Ann Arbor, USA, and then 1987, University of Michigan, Ann Arbor, USA, and then 1999, Master of Health Insurance Professional at Health Insurance Association of America, USA, and then 2000, Health Insurance Specialized at Health Insurance Association in USA. And then 2001, Strategic Leadership Development, a Learning Organization Approach, Gates Institute, Bloomberg, School of Public Health, Johns Hopkins University of USA. Okay, now we would like to welcome Professor Purnawan to start your presentation. You may start, Professor Purnawan. Thank you. Excuse me, Professor Punawan. We cannot hear clearly. Yeah, please. Rather, please keep your microphone. Okay. Still very low your volume. Could you please?
Hello?
Okay, this one is
Hello?
good. Okay, this one is clear.
Okay.
Yeah,
Let
you may
me,
start, Professor.
yeah, okay. Sorry. Because I'm using personal phone. Okay. Not a laptop. So maybe the sound is rather disturbing. This is a very important topic today and this year, especially about how we could safely practice in this pandemic times. So aesthetic, how we can keep practice aesthetic at this year or maybe next year also. Next slide. Okay. Maybe my topic is part is based on patient safety, like discussed by Prof. Razak Taha. But this is more enlarged area because not only patients, you have to also consider yourself. So you have to protect yourself first and your staff in your office before you can protect the patient. So there are a general rule, of course. We call it in here is healthy health protocol. You have to maintain space 1 meter at least and use the maskers. So actually by talking like this, I'm not according to, but because I'm already far from other people, so I take off my masker. And yeah, the thing is how you make your environment safe because this is also important. So you avoid 3C, mean close area, involve people, so to avoid close contact with people and crowded area. If you can make people outside the office and avoid crowded in indoor setting. So how we can apply this principle? Next slide. Next slide, please. Okay, there are three alternatives actually. The easiest one, just close your office temporarily. The next alternative, go telemedicine. Then I not prefer this, but if you like, you can continue practice, but make your clinic ready for COVID-19. First alternative. Next slide. Okay, the simple and the easy and the safest way is just close down your office temporarily. You stay at home, read a book, do paintings or other activities at home. Yeah. Because that's, I think, the safest one. Until when? Of course, it's temporary. Until the COVID is under control. You see, in Indonesia, COVID-19 is not yet under control. We are not reaching the peak. We are going back. So this is the most dangerous time to practice. And according to data, statistics, we already have more 200 right now. Doctors died, infected by COVID, dentists, nurses, paramedics. So I don't want you be the next one. Okay. Next alternative. Okay. This has been done by some of my friends. So I already asked my friends who are continue, who are close, and who are going to telemedicine. Some of them are going to telemedicine. If you see, because you now have a smartphone, there are a lot of clinics going to telemedicine. Why? Because most of aesthetic treatment actually is non-urgent, it's non-essential, can be postponed. Second one, now smartphone is very high resolution. You can see your face, your skin face, problems in skin, in other, in the eyes, in the ears, just by using the video or picture. So some clinics just ask the patient just send the pictures or have a video consultation. And telemedicine now is in line with the government advice. Government advice is mostly close down your office except in emergency. But for aesthetic, if there is emergency, just ask your patient go to the hospital. Okay, there are some offices that even successful doing sales. I mean, open your office by doing telemedicine. Okay, the last alternative. What happened if you, next slide, please. Next slide. Next slide. Okay, you plan to continue your practice, make your office or clinic ready for office. There are three things before the patient arrives. Okay, before the patient arrives, prepare the clinic. I mean, you have to have enough supplies, PPA, okay, and you know the area. There in Indonesia, there is a peduli lingkungan, so you know whether in your area is a red zone, yellow zone, green zone, yeah. And you have to make a plan for the patient. You have to communicate with the patient before arrive, whether they have symptoms of COVID. Now the symptoms are varied because they feel can be any symptoms now. Not only cough, could be diarrhea, could be rash in the skin, something like that. So beware and prepare the waiting area in your clinic. Take off all the magazines. Okay. Reduce the number of chairs. So they are in line with the health protocol guidance. And when the patient arrives, have staff in front of the office to check the temperature. Ask whether there is a symptom. If you suspect anything, don't let your patient come to your office. Ask them to go to the hospital instead. And after the patient leaves, clean your office again, disinfect again, change all the things, yeah, that contacted with the patient. Okay, the next slide. The next thing to do, you have to train your staff. Next slide, please. Next slide, please. Hello, next slide. Okay. No. Before that. Oh, God. Okay. But use the PPB equipment. Sorry. That's okay. Because you might not have done before, right before this previous slide. Okay, just stay in this slide. You have to prepare your staff. Maybe you are a doctor, know about COVID, but maybe your staff did not. So you have to train them to know all the symptoms now, again, the update symptoms about COVID, you know. Okay. implement procedure so they know how to use also the equipment. But more importantly, it's how to take off because some of your friends, some of the staff, some of the nurses prepare very good in placing the PPA, but bad in take off. So they got infected by taking off not carefully. And if your staff, if there is a symptom in your staff, just ask them to stay home. Okay, next slide. Hey, no, next slide. Next slide. Okay, because your PKA is not unlimited, you have to be careful using it. Yeah. Use physical barrier. Limit the number of patients by scheduling. Use telemedicine just if they just need to have a similar screen. Just use telemedicine. Limit the minutes you are talking directly with the patient. As in not urgent, postpone it or go to telemedicine. Next slide. Next slide. Okay, this is maybe the last one. Yeah, you can have a door sign. So the patient before seeing your staff see this and he or she has a symptom, maybe just go back to their home. Next slide. Next slide. Okay, this is the checklist. You just can return. This is the checklist, and you can use this, give it to your staff, something like that. Yeah, that there are about 11. You have to comply with the government rules. You have to plan your patient, reduce the number of patients, anticipate the various conditions, institute outings, emergency precautions, something like that. Please clean your environment, something like that. Yeah, can screen the patient, even though they say they don't have any symptoms. Always screen your patient. And it better, yeah, you know where they are come from, whether they are from the red area, yellow area, or the green area. Be careful also, there are legal implications if you get contacted or they get contacted because coming to your office. So beware. And that's the last one. Thank you.
Okay. Thank you very much, Professor Purnawan Junadi, for the explanation about how we fight COVID-19 in aesthetic medicine. So many things that we have to notice, yeah, when we want to do practice during the pandemic time. Thank you, Professor Purnawan Junadi. I wish you all the best. Success always for Professor Purnawan, and stay healthy, stay safe, Professor Purnawan. Okay, thank you very much,
Stay
everybody.
healthy.
So, yes, thank you. This is the end of the session of Ethico Medico Legal, and then we shall continue to the next session. In Asian countries, skin pigmentations still makes lots of cases. Yeah, we have lots of cases of pigmentations, and now today we have two speakers. Will talk about these pigmentations, and for the first speaker comes from Singapore. That is Professor Dr. Stephen Theng Chien Guan. Okay, is Professor Stephen already here? Hello, good morning, Professor Stephen. How are you?
Uh,
How are
Good
you?
morning. Good morning. I'm very good. I hope everybody is well and good in Indonesia.
Okay, yeah, fine. Thank you. Also in Indonesia. How is in Singapore now? Yeah, is the COVID already under control there? Okay, yeah.
Okay, so I need someone to. COVID is under control in Singapore. We are doing quite well.
Okay, stay safe, stay healthy. Okay, before Professor Stephen start the presentations, I will briefly read his CV. Professor Dr. Stephen Teng Kien Kwan from Singapore, education from MBBS Singapore 1992, MRCP UK, Royal College of Physicians UK in 1997, FRCP Edin, Royal College of Physicians UK 2012, and awards that he gets is United Nations Interfaith Medal in December 2000, Peacekeeping Medal, and then the Letterman Award, Best Overall Student, Ahmed Fort Sam Houston, San Antonio, Texas, USA in May 2001, and then current appointment as Chief Dermatologist, Skin Research Institute in Singapore, A-Star, as Senior Consultant Dermatologist in National Skin Center, NSG, and then Medical Director, Translational Research Office, National Healthcare Group. Okay, for Professor Dr. Stephen Teng Kien Kwan, we'll start with the presentation. Your topics is new strategies to protect against skin pigmentation. The time is yours, Professor Stephen.
Thank you very much, Dr. Santi. Can you all see my slides?
Yes, it's okay.
Okay,
Okay.
good. So today I'm just going to share with you some of my thoughts on new strategies to protect against skin pigmentation. But before I start, as usual, these are my conflict of interest. I do work with quite a few companies, partly as the director of the Skin Research Institute of Singapore, which I set up about 6 years ago. But for this talk specifically, I've got no conflict of interest at all. The details is going to be shared from research from my Skin Research Institute, as well as from some of my collaborators. So I bring you greetings from the National Skin Center. I don't know how many of you have joined us in Singapore before. This is where I was trained as a dermatologist more than 25 years ago. I've been practicing there for the last 25 years, and I'm the head of the Pigmentary Disorder Unit in the National Skin Center. Within there, we've got about 60 dermatologists seeing about 1,005 patients every day. This is a Skin Research Institute, which I set up about 6 years ago. So we've got about 400 researchers working together to look for new ways to better treat skin diseases. And skin pigmentation is one of the focus areas in the Skin Research Institute of Singapore. Also, I want to warmly welcome you all to the 25th World Congress of Dermatology, WCD, in 3 years' time. We successfully bid for it, and we hope that by then COVID will be away and all of us will be ready to travel again. And we look forward to welcoming you all to Singapore to attend this wonderful World Congress of Dermatology. Now back to my topic for today. I know that when I first started as a resident in dermatology, my mentor, Prof. Go, always tells me to look for 3 things when it comes to pigmentation. So first thing, look at the parents, right? When the patient comes in, look at the mother, because generally the metabolic genes we inherit from the mother. So if the patient has got bad genes, meaning a lot of melasma, a lot of facial pigmentation, likelihood of him or her getting early aging, getting skin pigmentation be much higher. The second question we always ask is always hormones, right? Do you take hormones? If you do, especially oral contraceptives, please stop them. Are you CD that contain hormones? If it does, stop them. If not, you get worsening of skin pigmentation. The third thing that we always ask is about sunblock. And we were focusing quite a lot on ultraviolet light for many, many years, I remember. And we always tell patients that it's important to use sunblock and to use sunblock regularly. But I think that just like many of you in your clinical practice, even if patients are very compliant with sunblocks, even they use things like SPF 100, and then you find that their skin pigmentation doesn't go away completely. And even they go away, many of them relapse very fast. So over the last 15 years, 10 years, we've been asking ourselves, is there something else that we're missing, right? Other than blaming patient for being non-compliant, we always ask, is there something else that causes worsening of skin pigmentation? other than genes, other than hormones, other than ultraviolet light. So today I'll share with you 4 things I think in the last 4 or 5 years we've gotten a lot of attention. I think it's something that we should all be thinking about as we manage our patients with skin pigmentation. Now, this is really looking at the spectrum of sunlight reaching the Earth's surface, right? If you look at it, only about 5% of UV reach the Earth's surface at sea level and 50% of visible light. We spend 100% of the time focusing on 5% UV, and we really totally ignored the visible light component for many, many, many years. So what if this visible light component does worsen the skin pigmentation? And over the last 5 years, we've started to learn that indeed visible light, especially the blue light range, does worsen the skin pigmentation quite a bit. Actually, I would say that we dermatologists are late already, because my wife, who is an eye researcher, has already known, the eye team has already known for many years that blue light worsens eye condition. It causes cataract, it causes macular degeneration and things like this. Only dermatologists over the last 4 years, then we realized that indeed blue light can worsen skin pigmentation. Why is it that blue light has not been looked at for so many years? That's partly because for many, many years, the studies are usually emerging from the Caucasian population. And you find that blue light is very interesting. It doesn't affect the Caucasian population. It only affects the Asian population, meaning skin type 3, 4, 5, and 6. So all the previous studies on skin pigmentation and light used to be done on the Caucasian type 1, type 2, maybe type 3 skin type, and it didn't discover this blue light problem. So this is the first study that published the problem of blue light. So they take patients, and then there are 4 corners. This is where they shine blue and red light. This one is not exposed. This is just to 1.5 MED of UVB, which is the usual skin pigmentation dose. And there's a blue light. And this one is immediate 4 hours. This is 48 hours. And this is 1 week later. And you can find that for the blue light pigmentation compared to UVB, it causes very much more darkening and is very much more persisting all the way down to 1 week down the line. So this is the first study about 6 years ago, published by some of our collaborators, that shows that blue light, especially for Asian skin, is a problem. There are a few more new research coming up that shows you the importance of blue light protection. And this particular study compares between blue light and UVA1. So on the left-hand side, you see immediately after shining UVA, 70 minutes equivalent to the sun, you find that there indeed is pigmentation. But if you look at the visible light, the blue light component, 70 minutes equivalent to exposure to the sun, you find that the pigmentation is much darker than UVA, and it persists longer than UVA. Again, this shows you that the component that we're missing all this while is actually more severe when it comes to causing skin pigmentation, and it's more persistent. Another study shows you the synergistic effect between UVB, visible light, and UVA1. So in this case, when you shine the skin with both UVA1 and visible light, you find that the pigmentation is much darker compared to pure visible light alone. So that's why it's important to block both the UVA and the visible light to totally abrogate the problem of sunlight and skin pigmentation. So we ask ourselves next, right? We know blue light causes it, but what is the pathway? We need to know the pathway so that we can either totally block blue light. If we're not successful at blocking blue light, we must at least be able to cut down the pathways. So there are a few pathways, and you find that the blue light acts through 3 main pathways. One is, of course, oxidative damage. They find that when you use blue light to shine on keratinocyte or keratinocyte co-cultures, the oxidative stress that's generated is actually equivalent to both UVA and UVB combined. So it's actually extremely high stress, oxidative stress caused to the skin when you shine blue light to the skin. The other thing is very interesting in the sense that this is from Passeron, our collaborator and team in France. They use pure culture melanocyte, and they use blue light to shine the melanocyte. You find that blue light directly activates the melanocyte, make it more dendritic, more pigmentation, and more tyrosinase. So there is a receptor on the melanocyte that actually absorbs and sends blue light. And you think carefully about it, actually this should not be surprising because the melanocytes comes from neurocrest, and they are the light sensing cells that's in the retina. So they should have got light sensors. And they find that in the melanocyte, there's a light sensor known as opsin 3 that absorbs blue light. And if you block opsin 3, you actually block the effects of blue light, 4.5 nanometer. You block opsin 3, you block the effects of blue light on melanocytes. So there's a direct receptor stimulation of the melanocytes by blue light on through opsin 3. The next interesting effect of blue light on the skin is on the barrier function. And this is a series of experiments where you put mice in various type of lighting, whether it's in total darkness, in white light, in blue light, and red light, and do tape stripping and see whether the barrier recovers. You find that the blue light, those mice that's kept in blue light, has a poor barrier recovery as opposed to dark white light and red light. In fact, red light mice placed in red light seems to recover the barrier very much better. So generally, we find that blue light causes pigmentation or damages the skin in 3 ways. 1, direct stimulation of melanogenesis. 2, oxidative stress. And then 3, of course, it causes a barrier function, barrier defect in the skin barrier. So first part that I think we should now think very carefully about is really as we tell patients to apply sunblock, which focuses very much on UVB, which is SPF, and UVA, which is your PA or IPD. You find that you have now got to start to look for ways to block visible light. And there are very few sunblocks out there that block visible light. Because this is a new knowledge, I think only in the last 1 to 2 years, then you start to see a few of these sunblocks that purports to block visible light. We shall talk about a bit more about it later on in my lecture. I want to quickly go on to the second component that we need to think about that really does cause worsening of pigmentation. And this component is actually not new, right? So this is a nice picture of the Singapore skyline on a very nice day. And below is a day when we have got a lot of smoke from the traffic and environment pollution. You can find that the pollution can be very bad seasonally. Now, the question has always been, does pollution worsen skin aging? If yes, how does it worsen skin aging? And does it worsen pigmentation at all? Well, the first study that shows you environment pollution and skin aging was published many years ago. I think a lot of people missed this paper, but it's a very interesting paper. So in this paper, they measure thousands of patients and they look at volunteers. They look at distance they stay from a busy road, if they stay less than 100 meters, or if there's a lot of soot increase, or there's a lot of traffic associated particles increase. They find that those volunteers, if you measure them compared to those that stays very far away from traffic or in the suburb or in the villages, you find that the number of pigment spots on the forehead and cheeks actually increases with increase in soot and increase in traffic particles, as much as also the skin aging from the wrinkles, the nasolabial fold. So this is the very first epidemiological study that shows you that pollution does cause skin aging if you're exposed to it in a long period of time. How about pigmentation and age spots? Another study which is interesting. So in this study, they look at nitric oxide, which is really a major component of traffic associated particles. If you're exposed to more nitric oxide than normal, you'll find that on the cheeks, you've got more pigmentation compared to those that are less exposed to nitric oxide. Same for China and also in Germany. What is interesting in this study is if you look at the same patients, but now non-sun exposed areas, underside of the forearm, as well as the back of the hand, you find that there is no such increase. So it seems to suggest that pollution works in conjunction with with light, whether it's UV or visible light, to cause worsening of skin pigmentation. By itself, it does not. So it is interesting to know the synergistic effect again of both pollution and ultraviolet light. These two works hand in hand to worsen your skin pigmentation. So back in our lab in Singapore, we decided to investigate how does pollution cause skin pigmentation. So these are very colorful slides of keratinocyte staining. So we grow keratinocytes, we stain melanocytes, we co-culture them, then we sprinkle polluted PM 2.5 particles, and we look at the pigment transfer and increased pigmentation. So you find that down here in the keratinocyte melanocyte co-culture, just pigment, putting PM 2.5 alone will give you an increase of 100% increase in pigmentation and transfer. And what's more interesting, S is actually senescent, meaning old cells. These are young cells. If you sprinkle pollution onto old cells, you find that the increase in pigmentation is magnified by many, many times. So somehow, pollution seems to affect the older cells more than younger cells. So as all of us gets aging, as we get older, like me, I'm about 55 already, I'm very cognizant of the fact that the pollution will affect me much, much more than my children, who's about 12, 13 years old. That's because the keratinocytes and melanocytes seems to be more resistant to the pollution effect for younger children or for the young people as compared to the older population. So we ask ourselves again, what's the mechanism of action? So there are 4 mechanisms of actions that pollution can cause skin pigmentation. One is, of course, it impacts the skin microflora, this is microbiome. Got no time to talk about it today, although we have a big program on skin microbiome in the Skin Research Institute. Again, back to reactive oxygen species, there is a huge rise in reactive oxygen species in patients exposed to PM 2.5 or the pollution particles. It acts through AHR, which is your aryl hydrocarbon receptor. You can look to block this. And pollution causes microinflammation. And the microinflammation, in turn, causes increase in skin pigmentation. And so this is, in the end, what it does. Ozone, AHR activation causes inflammation, collagen breakdown, increased risk of cancer, and of course, resulting in skin hyperpigmentation. So this is, again, how pollution can have direct effects on skin, how it affects the skin in terms of increase in skin aging, as well as how it causes increase in skin pigmentation. So this is the second leg of the table I want to talk about. That is, other than UV, we know visible light is important. I've shown you that pollution has a direct effect on skin pigmentation, and it works through oxidative stress and microinflammation. I want to very quickly go on to the third part, which is really cosmetics itself. I mean, this is a picture of one of those shelves in those supermarkets that you can find, whether it's in Indonesia or Philippines or in Singapore. And you'll be amazed that there'll be rows and rows and rows and rows of skin brightening components, sunblocks, and so on and so forth, right? And then you find that in all this, there are labels to tell you this hypogen, and they are dermatological tested, so they are safe. They tell people, sure, safe. Don't worry, just use it, right? So the question I've always asked myself is safe really safe, right? I mean, is it really safe, right? So I just want to show you some of the experiments that has been carried out, which would convince you that actually it is not so. Just one experiment. In this, we use titanium with in this experiment, titanium dioxide is very commonly used in sunblocks, right? We use titanium dioxide nanoparticles of different sizes. Very simply, we coat them onto they are coated onto the ears of the mice, right? And then we look for inflammation. So interestingly, if you look at this part side of the graph, you find that titanium dioxide by itself causes no inflammation. And that's where the company will tell you that it's dermatologically tested and is non-comedogenic, safe, doesn't cause irritation. True, because you test it purely with titanium dioxide. But if you coat the mice ears with a bit of house dust mite, and you add in titanium dioxide, you find that House dust mite will cause inflammation. All of this we know, right? Because it causes an allergic component. But together with the titanium dioxide, it magnified the inflammation 3 to 4 more times. So a lot of the cosmetics that we test is by itself, inert, safe. But we know that it's very far from the truth because in our daily activities, on our day-to-day exposure, we're exposed to pollens, we're exposed to allergens, we're also exposed to house dust mite. And then together with titanium dioxide in substantive individual, you find that actually it worsens the inflammation so much more. So it is really not true that the conventional testing that we do nowadays prove that it's safe. It's only proof that it's safe by itself, but not in combination with what we expose to the environment. So this study tells you, right, by itself, no increased inflammation, but with allergen, whether it's house dust mite or pollen or other type of allergen aggravating that irritates the skin, it will aggravate the inflammation. Now, this is a patient that I have, right, who swears that she has not used lasers, she has not used any hydroquinone. But if you examine the melasma very carefully, you find that she not only has melasma, she has this very speckled hypopigmentation, and all she has been using over the last 5 years have been over-the-counter products, right? So if truly that's so, how did this speckled hypopigmentation come about? Or my hypothesis is really somehow this patient, those things that is deemed to be safe is causing an increased inflammation, which results in a bit of this speckled hypopigmentation. And in a study that they do biopsy for patients with melasma, it's not surprising to see that actually on this right side, you can see that there's a half group of patients that you look at it, it's just pigmentation, but the biopsy shows that there are inflammatory cells underneath it. It's actually inflammatory melasma. So melasma by itself is not a pure pigmentation problem. It has got inflammation in at least half the group of patients that you probably are seeing if this study is to be believed. So the third component is naturally cosmetics, right? We know that it's very hard to pry patients away from cosmetics. All patients go through at least 7 steps before they sleep, right? They need to clean, wash, tone, serum, I can't remember, bleach, and so on and so forth. And all these things, layers upon layers upon layers add onto the skin. With the combination, I'm sure that it's probably doing more harm than good. And I always tell my patients, please keep things simple. Please keep things simple. 2 things why you should keep things simple. 1, it saves you a lot of money. 2, you can sleep earlier. You probably will be younger because you need to worry too much about applying cosmetic over cosmetics. And 3, you reduce the effects of this synergistic irritation effect that causes microinflammation. And the last component is, of course, the skin barrier, right? We always know that skin barrier is a problem in eczema because it prevents transient water loss, it prevents allergens and virus from getting in. But have we ever considered that skin barrier is an important component of pigmentation? We need to think about it because if you look on the market now, there's really a lot of things that people are using to wash the skin. You know, I mean, they have got brushes to electrical devices that promise patient that I'll rejuvenate the skin for you and then I'll wash your skin until it's really clean. We know that if too much washing, like now COVID, we keep washing our hands, we get inflammation. I'm sure that too much washing will also cause microinflammation or reduce barrier on the face. So what has got barrier function got to do with pigmentation? That is the first study that shows that if you look at melasma patient, lesional versus non-lesional, meaning you look at melasma lesion followed by a non-lesional in the same patient, you find that the barrier is much poorer in the lesion skin compared to the peri-lesional skin. That tells you again that on the lesional skin where the melasma is, where the skin pigmentation is, somehow the barrier is much poorer. In our own study, we took biopsies of patients and we separate the keratinocytes from melanocytes and we start to look at the genes that upregulate, downregulated. As a summary, we find that the lipid genes are downregulated, meaning that the barrier, the ceramides has reduced dramatically. And then there's upregulation of keratinocyte gene, and the keratinocytes are all poor. They are very, very hyper differentiated. So there is a distinct barrier dysfunction in melasma patients, at least in our studies, when we do a biopsies and we study the keratinocytes of those patients compared to the same patient but non-lesional normal skin. So we know now barrier is a problem. And we tell patients, I tell my patients now, keep things simple, don't wash too much, don't cleanse too vigorously, forget all those scrubbing devices. I think they are doing more harm than good. All right, so now that we know that there are these 4 things to think about other than ultraviolet light, so what should we do next, right? How can we better protect our patients? So this is what I call the ladder to success, right? First thing is really just counsel patients. So the first consultation I have with my patients usually take a long time because I think there's a lot of counseling to do. The first thing is to shift thinking. A lot of time patients have seen a lot of doctors. They've only been educated on ultraviolet protection. I tell patients that we're going to move away from photo protection to really environment protection, partly because I've shown you in my first half of my lecture that it is not just the ultraviolet light, it's a visible light, the blue light, it's a pollution, it's the inflammation, it's the cosmetics, and it's the barrier that's important. So we got to move away thinking that as long as we put ultraviolet light SPF 100, we are safe. Actually, you're only covering 1/3 of the problem because you're exposed to everything else. So again, stay away from the sun, right? Move away from pollution you can. And I actually encourage patients to stay indoors with HEPA filters if they're staying at home now, work from home, and their aircon, they get HEPA filters. I think it's probably better. And of course, keep away from blue light, right? The next thing, of course, now when you select sunblock, what are sunblock should we choose? How do we choose sunblock, right? So there are many types of sunblock, right? And it goes from SPF 30 to 60 to 100, and then the latest I've seen is 150. And the patients will ask me, so doctor, there's so many SPF, right? Does it mean that SPF 100 is better than SPF 50 is better than SPF 30? So what level should I use? Now, I think that it's very important to be very practical, right? Spending a lot of money doesn't mean that it's going to be you're going to achieve a superior protection. So this is very important for us to know, right? No sunscreen, you get 100 photons, a shine, 100 photons enter the skin. At SPF 15, you already achieve 93% protection, much better than about similar to your coronavirus vaccine now, 93% protection only at SPF 15. At SPF 30, you already achieved 97% protection. So can you imagine if you go to SPF 100, you only achieve maybe 1% or 1.5% more. Do you want to invest that type of money for that 1% more protection? My answer is probably no. Why is there SPF 100 then? That's really because it caters to the different type of skin tone. Now, all those SPF 100 are really from the Caucasian population preventing skin cancers type, right? For skin aging and pigmentation perspective, you really don't need that, right? So for us, Asia, we are usually medium or dark. Some of us are maybe a bit light. So you look at this light skin tone, the worst you ever go to is probably SPF about 50, right? Generally, I tell patients SPF 30 will do because we are only allowed to spend 4 hours outside. Anything more than 4 hours, you need to reapply again. So I don't look at 5 hours, partly because the sunblock, although in the laboratory testing say it can last for 5 hours, we know that in the outdoor testing, it doesn't last for 5 hours. I'll show you the data soon. So most of our patients, I'll tell patients, 30 will do. If you're darker, then the cheaper you can get, go for 15. That's all you need, right? Unless you're very fair, like the Caucasian type 1, type 2 skin type, then you think about SPF 50 or 100. Why do I say 4 hours is the limit before you reapply? This is a study. No matter what sunblock that you use, within 4 hours, all the protection has dropped exponentially. That's because of this, in our tropical environment, the heat, the sweat, and then sometimes we touch our face and the sun degradation of the sunblock. You find that even you go to SPF 100 that's tested indoor in lab, outdoors by 4 hours, it will have probably degraded by 50%. and you find that it's no longer useful. So it's very important to counsel patient to reapply at 4 hours rather than buy a SPF 100 and expect it to protect for 8 hours, because it doesn't work in that manner. Other than using SPF, which is your UVB protection, right? The next thing is really look for blue light protection. So look for those sunblock that protect blue light. And unfortunately, there's no measure of protection at this point in time. Like UVB, there's SPF, UVA, there's PA or IPD, PPD. For HEV, which is your high energy visible light, there is no degree of protection numbers per se. So people are going by percentage of HEV block. Look for one that can reduce pollution. Look for sunblock that can restore the barrier. At the same time, there should be some components that reduce microinflammation, right? So this is the ideal sunblock, right? Either it reflects or absorbs light. Look at the spectrum. Really look for HEV protection. Make sure it doesn't cause inflammation. It can restore barrier, sweat resistant, and then barrier against pollution, as well as antioxidants, which is very important, right? And there's a few sunblocks, and one of them that's just recently been launched has shown that it protect HEV by 54%, reduce microinflammation, and reduce barrier. So these are those sunblock which I think would be the next generation sunblock that goes beyond protecting against UV, but focuses on the surrounding factors, the environment factors that worsen skin aging and pigmentation. The third one is, of course, to target the downstream mechanism of pigmentation and aging. You find that actually skin, if you have been listening to my half an hour of lecture before this, skin reacts actually in only two ways. No matter how you insult it, it always reacts by two ways. One is either by oxidative stress or it's by microinflammation. So whether it's pollution, whether it's UV light, whether it's visible light, blue light, it always reacts via these two pathways. So oxidative stress is a common pathway for both visible light and for pollution and chemical irritation. So the question is, are antioxidants really useful? So we know we prescribe antioxidants, so we give ourselves a pat on the back. Studies have shown that the sunscreen plus antioxidants are better than sunscreens alone. Many papers have shown that. So again, when you choose sunblock, look for those that has got good, stable antioxidants. I caution you about vitamin C, because vitamin C must be formulated properly. If not, upon exposure to the sun, it's usually not stable. Now, the question next would be, instead of applying, can we eat antioxidants? I mean, nowadays all of us eat antioxidants and think that, wow, it's going to protect the skin, right? So is there any evidence to show that oral antioxidants can protect the skin? Well, the answer is yes, but not all. So in this study, which is interesting, right? They take 20 patients, volunteers, 20 take tomato paste, 20 take olive oil, and then for 12 weeks, and then they look at their reaction to UV rays. They find that those volunteers on the tomato diet actually has got better protection, reduction in skin redness, and mitochondrial DNA damage. So this shows you that oral antioxidants does work for skin prevention of skin aging or preventing skin damage from UV rays, right? Another study, this is looking at the general antioxidant in the blood, and you find that if you take blueberries, again, there's a reduce in oxidative stress. So this again tells you that oral antioxidants does work. The question is now, if you want to take oral antioxidants for skin protection, what should you take? Most antioxidants goes to the blood, goes to the liver, and then they don't concentrate in the skin. So studies have shown that there are only a few antioxidants that concentrate in the skin, right? So those are the ones that you want to take to prevent skin aging and prevent skin pigmentation, because you want the antioxidant not to go to the blood and liver and disappear. You want it to be concentrated in the skin. So you find that the Polypodium leucodermis, which is a herb, a Spanish herb, and then lycopenes, all these luteins are the special antioxidants that concentrate in skin. And that's why when you take a lot of papaya, a lot of tomatoes, your skin gets a bit of reddish, a bit of orangey. That's because the pigment concentrates in the skin. So this is studies to show you that if you take Polypodium leucodermis, which is a Spanish herb, 2 hours before UVB, you find that there's a reduction in apoptosis, there's reduction in mitochondrial DNA damage. For skin pigmentation, we've run quite a few trials on oral antioxidants that concentrate the skin. For melasma treatment, you can find that in this case, in this study, this group, there's a significant reduction compared to placebo group. And this double-blind placebo control trial of a specific antioxidant that concentrates the skin that improves the treatment of melasma. Right? Another study of a different type, again, you find that compared to placebo, the reduction of MASI score is very much more significant than the placebo component of it. Again, this shows you that oral antioxidants that concentrate the skin does work. And if you use it together for treatment of melasma, it does help quite a bit, right? So the next thing, of course, is a microinflammation, DNA damage. Is there anything you can take to prevent mitochondrial DNA damage? Very not many studies at this point in time of things like this, other than something for cancer prevention. I took note of nicotinamide, which actually you can find in a lot of cosmeceuticals nowadays. You find that in a double-blind placebo control trial, this one's looking for cancers because that's the most extreme mitochondrial DNA damage from UV rays. You find that in patients that take nicotinamide, there's actually a better protection against all those UV causing skin cancers like your SCC, your BCCs, your non-melanoma skin cancer. And extrapolating this result to skin aging, because it's all skin damage, you find that it's probably the same, right? So this the ladder. This is the ladder of success I talked about. Now, of course, when the patient has got melasma, then you start to treat them, and there's a total separate lectures altogether, right? So I think I've finished about an hour. Oh no, half an hour already. So I'm going to just sum up at this point in time. If you forgot about all the things I've said in the last half an hour, I just got one slide for you. So remember, as you treat patients with skin pigmentation, really counsel them. Very important to counsel them with regards to behavior change. Don't just look at the sun, look at pollution, look at blue light. All right. Simplify your skincare routines, right? I tell patients 5-step, 6-step, 7-step, 10-step is too many steps, right? Just wash your face, moisturize, and then maybe one of those lightening creams or retin A. That's all you need. And forget all the other serum and whatever toners and whatever. I think it's just too much. It's just too much. Choose the ideal sunblock. Make sure you don't just look at SPF and IPD or PPD, right? Look at protection for visible light, look at protection for pollution, look at barrier restoration. And finally, make sure that it does contain topical antioxidants, or you can supplement patient with oral antioxidants, and those that concentrate in the skin will be very, very useful, especially for skin aging. So that's all I have for you all for today. I hope that it's opened up some of your thinking, and I'm open to any questions that you might have. Thank you very much.
Okay, thank you very much, Professor Stephen Thang. This is a very nice presentation, and for all audience, if you would like to give questions to Professor Stephen, please write down your questions in the questions box. So we're waiting for your questions. I will read the question, and then Professor Stephen will discuss about it. Okay, while we're waiting for the participants to give questions, I would like to ask Professor Stephen about UV, about you mentioned about visible light, blue light, yeah, that cause also for melasma. Could you please explain? Sometimes we do not realize where do we get the blue lights contacts in our daily. Could you please explain so which one that we should avoid blue lights to prevent the melasma or problem skins, please?
Okay, so blue light, you get it mainly from the sunlight, right? That's probably the
Okay.
stronger exposure of blue light that you get in terms of the irradiance, the power, and the strength of it. Then there are also all the other lights that we're exposed to. So nowadays we use a lot of LED lights, which is energy saving. And what's interesting is in
Okay.
LED lights, it's got a very huge blue component too. So the lights, indoor lights that you get also has got blue. The television screen, your iPads, your iPhones, all those emit blue light. The question now is, are those strong enough to cause skin pigmentation? I think studies needs to be done to understand that how much of this exposure for how long will give you your increase in skin pigmentation. Notice what I say. I didn't say that the television, all the screens will cause worsening pigmentation. I say they can. It's just that they emit blue light, but the blue light irradiance, in terms of how strong it is, how much before it causes increased pigmentation, needs to be further studied. So in the meantime, I tell patients, whether you're outdoor or indoor, please apply sunblock. In the past, it was
Okay. Okay. I see, Professor
everywhere.
Stephen too.
Yeah.
Yes. Yeah. Nowadays, during the pandemic, we every day we see the phone, see the iPad, iPod, everything. So we contact always with blue lights. Okay. We already got questions. This from the question box. This is from Dr. Kisanti. Excuse me. How to pick the best sunscreen based on skin type, and what should we check on the scent? This is from Dr. Yoselin. Please, Dr. Stephen.
Okay. So from a skin type perspective, you look at my slide, which I've shown just now. So it's really from a SPF perspective, right? Because in SPF, it affects how the way the light is being absorbed and how the UVB affects the skin type. So this is the slide always used, right? If your skin tone is light or medium, I tell patients generally SPF 30 will do. If you're very dark, then even SPF 15 will do. And this is really from an SPF perspective, right? From a UVA perspective, I would say that you generally need to select those that are at least BA3 plus and above. Those are just looking at UVB and UVA. And then on top of that now, you got to go inside and look at what other protection, other UVB and UVA does it protect. You must protect against blue light. So there must be a degree of protection against blue light, whether it's 10%, 50%, or 60% protection with blue light. And then does it protect against pollution? And then make sure it has antioxidants inside there. As for brand, you got to just look at it yourself because different countries got different brands. Yeah.
Yes. Okay, I see.
Yeah, that's
Thank
right.
you. Another question. This one is from Dr. Kisanti. Dr. Stephen, what's your opinion about skin genomic tests regarding the risk of pigmentation? Skin genomic tests.
I think that certainly is a very interesting area. We call it personalized cosmetics nowadays, right? If you hear what I say at the very first slide, I said genes is an important component, right, of skin pigmentation. The question now is, how do you identify the composition of genes that will predict that you get increased risk of skin pigmentation? I think the knowledge is not there yet. The knowledge is not there yet. So as at today, I will not recommend skin genomic tests to predict risk of pigmentation. Not as of today, because the knowledge, the research is not there yet. Maybe 2 years down the line, there's enough knowledge to say that this combination of genes will give you increased melasma. Then we can recommend that and do a genomic testing.
Okay. Okay. Thank you. And then we've got another questions. This one is from Dr. Meta Vitari. Morning, Dr. Stephen. What is the correlation between UV protection and simple skincare routine? So the correlation between UV protection and simple skincare routine.
Okay, I think that the correlation really is between use of sunblock and UV protection, right? I think all your other skincare routine doesn't really affect your sun protection capability at all. So the only thing that protects against you from the UV protection has got to be the sunblock that you apply. Of course, if you note my lecture, I said that skin barrier is a very important component. So even though you protect yourself against the sun very well, and then if your skincare routine has got no barrier restoration, meaning you don't apply moisturizer regularly, then it make you more susceptible to the harmful effects of UV and blue light.
Okay. Okay, I hope this, Dr. Mehta, I hope this answer your question. And then still about the sunblock, Professor Stephen. Nowadays, everybody's doing exercise outdoor, bicycling, and doing exercise everywhere. And when they're doing exercise, they use sunblock. And then the patient asked to the doctors, when I do exercise, I use sunblock. Actually, is this good to create, I mean, to stimulate vitamin D3, because we want to contact with sun rays to stimulate vitamin D3. What do you suggest for this patient? So lots of patients ask about this to us. Please, Dr. Stephen.
But my point to them would be like this, right? I said that certainly the vitamin D is important, right? So what do you value more? Do you want to be very healthy and very young looking, or you want to be very healthy and then your skin is all aged up? But that's a joke. I would say that I'll tell patients most of the time, just protect your face because that's most important. And then when you go outdoor, right, your normal exposure, your legs, your hands, your arms is good enough to get you your vitamin D exposure to get vitamin D. So just protect the face. So you find that the sun protection is quite different in Asian compared to Caucasian. In Caucasian, you do sun protection from a skin cancer perspective, right? You don't get skin cancer. In Asia, because our skin cancer, the melanoma risk is very low. A lot of time, our sun protection is really a skin aging concern rather than a skin cancer concern. So that's why I said that for if you worry about aging, protect your face, your hands and legs, just carry on, and you get enough vitamin D from there.
Okay, yeah. There's another questions now. Then we should reapply the moisturizer and sunblock regularly. Wait. Wait. No. When we're outside, do we have to reapply moisturizer and sunblock regularly? This is question from Dr. Mehta again. Yeah, this is still wondering about sunblock and moisturizer.
Yeah, I think that you need to apply minimally sunblock every 4 hourly. Sunblock every 4 hourly, and then if your sunblock has got and your sunblock has got ceramide content, then that's good enough. It's a 2-in-1.
Okay, now we've got another questions, Professor Stephen. This one is from Dr. Ubeta. What kind of cream that can protect from pollutant? You mentioned in your lecture that pollutant can also stimulate pigmentation. So this is the question about this pollutant.
Yeah, pollution is difficult. So that's why I said that you need to understand the mechanism of action from the polluting pathways. So in the lecture, you find that the mechanism of action is by 1, HR receptor, 2, by oxidative stress, 3, by microinflammation. So you can tackle the pollution downstream effect by having antioxidants and anti-inflammatory. So that prevents the pollution downstream effect. The aryl hydrocarbon receptor inhibitor don't have at this point in time, so you will still have this problem of pollution causing aging via that receptor until there is something new that can block the HR receptor that prevents the downstream effect of pollution. Then you get a complete block. For now, you got to look for those that sunblock or moisturizers that has got high levels of antioxidants, at the same time has a bit of anti-inflammatory component.
Okay. And then we went to the next questions is from Dr. Tias. Hi, Doc. A very good presentation from Professor Stephen. How do we recommend when to use chemical and SPM to physical sunscreen. So how do we recommend physical sunscreen?
Yeah, actually, physical sunscreen always works better than chemical sunscreen. The problem with physical sunscreen is because of the tint, right? A lot of time, the physical sunscreen tends to give you a very white complexion, a very ghastly white tint. So that's why chemical sunscreen comes in. Um, so the best effect is always physical sunblock. But if the color, that's why I said cosmetically, is not acceptable, meaning that the skin tone of the patient is slightly darker, you can't find the right tint for physical sunblock for the patient, then you go for chemical sunblock. And then in the chemical sunblock, it's the same principles. Look at the SPF, look at the PA, look at the visible light blockage, and look at the anti-inflammatory component.
Okay, I see. And then the next question again. This one, pollution. If someone prone to pollution, should we cleanse our face first? As I saw in the slide, we shouldn't cleanse our yeah.
And that is no, I
Our
didn't say
face
we
too often.
shouldn't clean our face. I say we, yeah, I say we should not be cleaning our face too vigorously, using all those scrubs and
Okay.
vibrating devices
Yep.
and things like that. Yes, face wash is still important. Wash at least twice a
Yep.
day. Be careful the chemicals that we use to wash the face, and try to not cause friction on the face.
Yes, because during the pandemic, yeah, Professor Stephen, I think in Singapore, also in Indonesia, everybody wash our face more than 2 times a day, maybe 3, 4, 5, 6 times a day. And some patients comes to us with irritation problems, itchy, and many, yeah, related to acne. Yeah, yeah. This becomes a dilemma for us. Yeah, when to do
That's
washing.
right.
If someone comes to you, the patient with like this, what will you suggest for the patients? I mean, usually for the soap, for the facial soap, also for the body. What will you suggest for the patient?
Generally, I'll tell them to use non-soap soap still. I'll still use all those like your usual Cetaphil, QV, those type. Um, and I'll tell them not to use scrubs. And then the moisturizer um, must be applied immediately after that, and then apply moisturizer more often.
Okay. Okay. Thank you. We've got another questions now from Dr. Mariana Saputri. What if patients have acne and hyperpigmentation? Can they apply sunblock? So a patient with which has acne and hyperpigmentation. Okay.
Okay, so I think that's a different problem now. In acne and hyperpigmentation, the first thing that I'll do is to be very aggressive in the treatment of acne. I will not focus on the pigmentation first because no matter what you do, you must stop the acne inflammation, right? If you can stop the acne inflammation, the pigmentation will slowly go away. So the primary goal of acne treatment is to treat the acne first, stop the inflammation. Only when acne is not active, then we think about the hyperpigmentation. And that's what I always tell all my patients. I say, don't worry about pigmentation. That's not my primary concern at this point in time. My primary concern for you is to make sure you got no more outbreak, right? So once you can stop it totally, then you go on the pigmentation treatment. And you try not to do two at the same time because they are contradictory to each other.
Okay. Okay. Thank you. And then we go to another question now from Dr. Megawati. Good morning, Professor Stephen. How
Morning.
important is PA? Sorry. Wait. Wait. How important is PA in sunscreen? Is it something necessary that we have to consider PA in sunscreen?
Yes, yes. So
Okay.
yes, of course. So you know what I said just now. I said SPF is a measure of UVB protection. PA is a measure of UVA protection. So I've shown you that the UVA and visible light work hand in hand. So you got block both. So PA must be at least 3 plus and above so that you will be assured that you have enough UVA protection. So you got to select SPF 30 and above, PA 3+ and above, HEV protection, and anti-inflammatory.
Okay. Okay, thank you. And then we go to the next question. Hi, President Stephen. I would like to ask about sunblock reapply. How would you recommend steps? Maybe that means in a day, if we reapply sunblocks, do we have to cleanse the first layer, clean first, and then apply another, or how do you suggest?
Okay, it all depends on what's the routine of the patient, right? If the patient has got nothing, just sunblock and moisturizer, then you don't need to wash. You just apply a second layer of sunblock. If the patient is an office going, working a man or woman, and then has got a woman at least, but has got foundation and things like that, then I actually tell them that very hard to keep washing your face to apply sunblock and then cosmetic again. Look for those foundation or powders that has got SPF 30 and above, right? And then you just top up your foundation or you top up your powder, and that's good enough.
Okay. Okay, we go to another questions. Wow, we got a lot of questions for you, Professor Stephen. Now,
It's all right.
one by one. So, hi, Professor. Wait, hi, Professor Stephen. I would like to ask about sunblock reapply. How would this one is continue to the first question, especially for makeup users or public transportation users. So, she means so this also means if someone use sunblock and then also with makeup and then we want to reapply sunblock, how do we use?
Yeah. So that's right. In my previous answer, I said that for this specific group of people, I always tell them then make sure your foundation or your powder has got SPF 30 and above. And you can find them nowadays. All the cosmetics has your foundation does got SPF protection. So keep that. Right. So don't need to reapply, but just top up your foundation and your sunblock. Oh no, foundation or your powders.
Okay, yeah. I think it's enough for this. In question box, we have no more questions, but I have another question for you. Talking about skin barrier. You said that barrier defect can also stimulates the hyperpigmentations. If someone has prone to get skin barriers defects and then gets problem to skin inflammation and then becomes pigmentation, how do we treat or how do we manage the patient with this?
Yeah. So that's why for these people with barrier defect, moisturizer is probably important. Restoring the barrier is important. So you got to look at how best restore barrier, and then for that, it's really choosing the right type of moisturizer. Moisturize as often as you can. Choose the right type of face wash or body wash so that you do not wash away your barrier.
Mhm.
And is there any supplementation to restore barrier? At this point in time, there isn't.
Okay, thank you, Professor. Okay, we got another questions from the audience from Dr. Mariana. Another question is for VR is applying foundation and sunblock can help to reduce from visible light. Yeah, she means sunblock. Can we use applying foundation and sunblock? Can it reduce from visible light? Yeah, please, Professor Stephen.
Okay. So this is a good question. I don't have an answer for you. I know that some sunblocks can protect against visible light, not all sunblock, right? So that's why you got especially look for those sunblock that's got visible light protection. I would say that most sunblock don't have because it was never a component that people are formulating to protect against. But because of the new knowledge about visible light, there are now on the market more and more sunblock that protects against visible light. So not all sunblock do, some sunblocks do. Foundation wise, I don't think they have caught up with it yet, so they're still at SPF levels. So there's nothing about foundation and blue light at this point in time.
Okay, I think. Yeah. Is there any questions from audience? We still have around 5 minutes. Yeah, I'm still waiting for audience. Is there any other questions? This is very interesting. Yeah. What Professor Stephen sharing about pigmentations. Yes, This is new knowledge for us. Yeah. And maybe Professor Stephen, could you please give some conclusion or take-home message for all the audience? These are all the doctors, major from Indonesia, and Indonesia have uh, almost the same problem with Singapore, yeah, because tropical countries,
Yeah.
pigmentation is so many problems, pigmentations, yeah, and they're recurrent. Please give some conclusion
Yes.
and take-home message.
So my conclusion has been still the same slide that I used in my last slide, right? I said, generally, please counsel patient on behavior change. Don't keep thinking about just sun. Think about environment. Because once you start thinking about environment, you start to think about pollution. You start to think about visible light, right? I always tell patients keep your skincare routine as simple as possible. More doesn't mean good. In fact, more usually makes things worse. And then as you look for sunblock, don't just focus on SPF. Look at the PA, look at visible light, and make sure it's got barrier protection and make sure it's got antioxidant. That's all.
Okay.
I think that we, at this point in time, with this knowledge that we have, this as best as we can go. Maybe 1 year, 2 years down the line, there'll be more new things on the horizon.
Okay, thank you very much. Professor Stephen, there is still one questions coming. Could you please still answer one question? Yeah, this one is from
Sure.
Dr. Okay, from Dr. Kisanti. How about sunblock supplement? So we know that some products they have supplement sunblock. What do you think about this? Does it really work?
I'm not a sunblock Superman in Singapore. Uh, so I got no idea, what is this sunblock Superman.
I s-
Got to look at the ingredients and the labels.
yeah.
Yeah, I don't know what's a Superman sunblock. Never heard of it before.
Okay, yeah. Okay, so thank you very much. I think we have so many discussion. This is really great. Yeah, thank you for sharing with us, Professor Stephen Teng Ting Kwan. Yeah, success for you always, and stay healthy, stay safe. Hope next time we will meet in Indonesia. Come to Indonesia if pandemic already overcome. Okay, we will
Sure,
have
sure,
another event. Thank you very
sure.
much, Professor
Thank
Dr.
you.
Stephen
All
Ting
right.
Ting
Have a
Kwan.
great day. Keep safe, everyone. Keep safe. Keep safe.
Yes, have a great day. Yeah, thank you.
Okay.
Everybody, we have got a very nice discussion with Stephen Tintingguan, but we have something that will appear in your screen, and after that, we'll continue with the next speaker. Okay.
Start from like 5 minutes ago.
Hello, everybody. Welcome again. We're still in virtual Iswam 2021, and now we're still in session 1 with the topic of skin pigmentation, how to deal with it. So, in the next session, we shall meet a doctor from Switzerland. Yeah, his name is Dr. Behros Kasrei. And Dr. Behros Kasrei will talk about the science behind cysteamine, the new alternative or hyperpigmentation. So let's welcome Dr. Kasrei. Hello, Dr. Kasrei. Good morning.
Hello to everybody. Thank you very
Hello.
much. Thank you
Yeah.
for giving me the opportunity to speak about cysteamine and the science behind it. So could you
Yes.
please go to the next slide?
Okay. Before you start the presentation, I will briefly read your curriculum vitae first. And we are very sorry we have because we have to disturb you so early. This is so early in the morning, 5 o'clock maybe in Switzerland. Yes.
That's not
So
a problem.
sorry.
It's a pleasure.
Okay. So I shall read your CV first. Dr. Behros Kasre from Switzerland, education from FMH dermatology exam successfully passed in November 2009, Federal Medical Diploma, Switzerland in November 2010, dermatology residency in Department of Dermatology of Geneva, University Hospital Geneva, Switzerland, 2002, 2003, and 2006-2010. Medical Doctor 2003 Shiraz University of Medical Science Shiraz, Iran. Pigment Cell Research Principal Investigator of Skin Pigmentation Projects in the Department of Dermatology, Geneva University Hospital, Switzerland, 2002, 2003, and 2006-2010. And now responsibilities Dr. Kesre as a chairman and CSO scientist as a Avenue de Sequeron 15 to 1202 Geneva, Switzerland from 2011 until present. So now the time is yours for Dr. Kesre presentation, please.
Thank you very much. Thank you for your complete presentation. So could you please go to the next slide? No. Next. No. So as dermatologists, we know that we are every day confronted with different skin hyperpigmentary problems, such as melasma, lentigos, post-inflammatory hyperpigmentations, etc. Depending on the region we are practicing, we can have more or less of these hyperpigmentary disorders. But the treatments that we have at hand for these problems are nearly the same everywhere in the world. Next, please. Next. You can go to the next slide, please. Still the next. So these are all hyperpigmentary disorders. I'm not going to spend much time on them. All of you already know this. About the treatments, we know that one of the most known treatments that we use every day for these hyperpigmentary disorders is hydroquinone, either in the form of simple formulas containing 4% hydroquinone or those which are combinations of hydroquinone with retinoic acid and with corticosteroids as the known Kligman's formula. If we do not like to use hydroquinone for any reason, we know that other options exist, but their efficacy is a matter of question. Sometimes they have better safety than hydroquinone, such as, for example, arbutin, such as azelaic acid, etc. But the problem is that their efficacy is not as high as hydroquinone. And if we are in front of an agent such as tranexamic acid, which is more effective than other agents, we would again have a matter of safety. Because as we know, tranexamic acid can produce thrombosis, and this is a problem which is serious enough to prohibit the dermatologist for its long-term use. So with depigmenting agents, either they are effective, but they have matters of safety, or they are safe, rather safe, but they are not as effective as we would like. Next, please. So the question is that, can we have an agent which is effective and at the same time safe? What does it mean to be safe? Being safe means it is not mutagenic, it is not carcinogenic. As we know, these are the matters of concern with hydroquinone actually. And it is not toxic. If possible, the agent should be biologic. And of course, it should be an effective depigmenting compound. So we are introducing a new molecule, which is called cysteamine. First of all, what is cysteamine? Cysteamine is the simplest aminothioal which is present in the human body. When we ingest the amino acid cysteine, it is converted to cysteamine. In fact, its carboxylic group is removed in our body, and it is converted to a thiol molecule, which is called cysteamine, which is a very potent antioxidant. So it's already present in all human cells. Next, please. Whatever you eat contains cysteamine. When you eat milk, when you eat meat, or when you eat every part of the animal's body, you are ingesting cysteamine already. The concentration of cysteamine in human milk is very high. It is nearly one of the highest concentrations present in a biological liquid. Why the Mother Nature has put this high concentration of cysteamine in human milk is not very well known, but very probably there is some protective role against the environmental oxidants to protect the baby. Next, please. In 1966, for the first time, an investigator who was called Chavin injected cysteamine into the black goldfish skin and found that after a few days, the skin of that black goldfish turned into white. So this was the first time that cysteamine was introduced as a skin depigmenting agent. 2 years later, Dr. Fitzpatrick and Dr. Blehan worked on other animal models to compare the depigmenting efficacy of cysteamine with that of hydroquinone, which was known at that time. They found that cysteamine is more effective than hydroquinone in producing skin depigmentation in animal models. They had compared 5% cysteamine with 5% hydroquinone at that time. And cysteamine proved to be a more potent skin depigmenting compound. Next, please. In 2020, cysteamine was investigated for its in vitro depigmenting activity. Please, I think there is an echo in my sound. I hope it will not bother the audience too much. So it was found that when cysteamine is put in high concentrations, as high as 100 micromolar concentration on B16 melanocytes, it produces a very effective inhibition of melanin synthesis in that cells without killing them. So it was the first time that the depigmenting action of cysteamine was shown to be the inhibition of melanin synthesis, not melanocytotoxicity. It does not kill cells. If we compare it to hydroquinone, in fact, at same concentrations of hydroquinone, no melanocytes would no more exist because hydroquinone kills all melanocytes already at 10 micromolar concentration. Next, please. Next. So in fact, I was working with cysteamine as a positive control in the laboratory when I was working the laboratory for research projects for finding new depigmenting agents, I was always using cysteamine as the positive control because it was a non-cytotoxic molecule and produced depigmentation. We wanted to find something like cysteamine. Why not using cysteamine itself? The problem was that cysteamine had a very, very bad smell. And that is why researchers were never able to make it into a depigmenting cream utilizable in human. In fact, Dr. Patak in 60s tried to make a cream containing cysteamine, but finally he found that the bad smell of cysteamine, which had a very bad skunky odor, was so bad that he could not cover it by any perfumes. The other problem was that cysteamine was very unstable and it degraded very rapidly in cream conditions. So he could not produce a stable cream containing cysteamine. When I was using cysteamine as a positive control in my studies, once I made a mistake and I added a wrong solvent on cysteamine when I was preparing solutions of cysteamine to expose cells to this agent. And the next day, I found that this solution of cysteamine was odorless. There was no smell. But the odorless cysteamine was still effective as a depigmenting agent when I used it on B16 melanocytes. So it was the first time that I found we can deodorize cysteamine using different substances, different molecules around it. And this was the beginning of the story of cysteamine cream. What is the mechanism of action of cysteamine? We know that in the melanogenesis pathway, we have the conversion of tyrosine to dopa, dopa to dopaquinone, and then dopaquinone continues to produce dihydroxyindole and dihydroxyindole 2-carboxylic acid, which are then polymerized to produce melanin pigments. Cysteamine inhibits the conversion of tyrosine to dopa and dopa to dopaquinone by the inhibition of tyrosinase and the inhibition of dopa oxidation. And it also inhibits peroxidases, which are responsible for the oxidative polymerization of dihydroxyindole and dihydroxyindole 2-carboxylic acid to melanin pigments. Another mechanism of action is that cysteamine quenches the ions of copper and iron, which are responsible for the non-enzymatic conversion of tyrosine to melanin. Next, please. Next. So there is just a small explanation about rebound and recurrence because we are going to use these terms in the presentation. When we say recurrence or relapse, we want to say that the situation of the patient comes back to his or her previous disease situation. For example, melasma lesions have been treated, they have gone away, we stop hydroquinone, and the lesions come back like before. When we say rebound, we would like to emphasize that when the lesions come back, they are worse than before. This is what happens in the case of corticosteroid use, for example, for the treatment of hyperpigmentary disorders. When you stop corticoids, lesions can become worse than before. Next, please. So if you compare the mechanism of action of cysteamine with other depigmenting agents, you find that cysteamine is a multifunctional agent that inhibits not only tyrosinase and dopa oxidase activities, it also inhibits peroxidase, it increases intercellular glutathione, it quenches copper and iron, while other depigmenting agents usually do not have all these properties and are inhibitors of one or maximum two enzymes in the melangenesis pathway. This might explain the higher efficacy of cysteamine compared to other agents that we recognize in our clinical practice. Next, please. So, when we found that cysteamine can be deodorized and be put into cream conditions, I was associated with a chemist and we worked on cysteamine formulas for about 1.5 years. And after that, we managed to have a formula containing cysteamine which had much less odor compared to cysteamine and which was stable. In fact, cysteamine molecule was stable up to 2 years. It was the time that we investigated cysteamine the longest time, and it was quite stable after 2 years in cream conditions. So we began to perform studies on cysteamine cream to see its efficacy. We did a first study in 2013 in association with Dr. Shu, who showed that cysteamine cream is effective in melasma patients, but it was a non-controlled trial at that moment using, if I remember well, 6 melasma patients only. After that, a double-blind randomized placebo-controlled trial was performed in 50 melasma patients, and it was shown that cysteamine is more effective than the placebo alone. Another study was done later comparing cysteamine with the Kligman's formula. In this study, it was shown that cysteamine is at least as effective as Kligman's formula for the treatment of melasma patients. A last study was the comparison of cysteamine cream with tranexamic acid, with injectable tranexamic acid, and it was shown that cysteamine is as effective as tranexamic acid. In both these trials, in the Kligman's trial and in the tranexamic acid trial, in fact, cysteamine was doing better. If you look at the data, it was doing better than the Kligman's formula and tranexamic acid, but the results were not statistically significant. We are going to look at these results. Next, please. So first of all, the BJD study, it was done on 50 melasma patients. Half of them were using cysteamine cream and the other half were using placebo. Next, please. After 8 weeks of application of cysteamine or placebo, it was already shown that there is a reduction in the melanin index of lesions in the cysteamine group compared to placebo group. And this reduction was still more significant after 16 weeks of application. Next, please. The comparison of the modified MASI score in these patients confirmed these results. After 8 weeks, the MASI score was reduced, and after 16 weeks, the reduction was still more significant. Next, please. This is the results of another study. In fact, it is not the same study. It was another study comparing, again, cysteamine cream with the vehicle alone. And it shows the high efficacy of cysteamine cream compared to vehicle when it was investigated by the investigators' global assessment and the patient subjective idea on the efficacy of both of these treatments. Next, please. So in some sporadic cases, we recognize that when we treat them with cysteamine cream, we have better results if we compare it with the Kligman's formula. I had a patient with phototype 5 who came to me and who had used Kligman's formula for several years already. Go to the next slide, please. This is a very interesting case. In fact, when she first came to me, she was using the Kligman's formula for already 3 years. If you look at the image on the left side, you see that the patient still has melasma lesions. And not only she has melasma, she has some signs of skin atrophy. I don't know if you can see the image well. Around the melasma lesions, you have some hyperpigmentations and some redness. In fact, when I saw her first, she also had telangiectasia in her lesions. She had hyperpigmentation around melasma lesions, and these were the signs of skin atrophy induced by the Kligman's formula. She was using the Pigmanorm cream, which is 5% hydroquinone, retinoic acid, and dexamethasone. She had tried to stop Kligman's formula for several times because of this skin atrophy, but she had never managed to do that because every time that she tried to stop the Kligman's formula, she had skin burning, erythema, and other signs of steroid dependence, and she had to use the Kligman's formula again. I stopped the Kligman's formula and rapidly began the application of Cystamin cream 15 minutes daily. I'll speak more about that 15 minutes daily because this is the protocol of Cystamin use. It is not to be applied for very long times daily. It's only 15 minutes of application. After 16 weeks of use, as you see, melasma lesions are almost gone away. And not only melasma lesions are away, that hyperpigmentation around the lesions is also away. This is not what I expected because Cystamin itself is a depigmenting agent. So it had to aggravate this hyperpigmentation and depigment the skin still more. But this had not happened. Not only it had depigmented melasma lesions, but it had repigmented the hyperpigmented areas around melasma. The patient continued the use of Cystamin cream, and the last image that you see is the patient after using Cystamin cream for about 5 years. As you see, melasma lesions are away, no signs of skin atrophy is present, and this last time I think I saw this patient maybe 6 months ago, and she was still very happy using Cystamin. So as you see, something that Kligman's formula was not capable of doing, Cystamin had done. It had removed melasma lesions completely. And it had also removed all the side effects of topical Kligman formula. Next, please. So after having these interesting results, an investigator, an independent investigator, compared the efficacy of Cystamin cream with the Kligman's formula and used two groups of patients, two groups of 25 patients each, treating each group with topical application of either Cystamin cream at night for 15 minutes and the Kligman's formula the whole night. Next, please. As we see, Cystamin was more effective than the Kligman's formula in the reduction of modified MUSI score in these patients. In fact, it had induced 27% more MUSI score reduction after 8 weeks of application and 18% more MUSI score reduction after 16 weeks of application. The difference was not statistically significant, but it is possible that if we had used more patients or if we had continued this study more, these data could become significant. So comparing Kligman's to Cystamin cream, the conclusion that we can have by this study is that cysteamine is at least as effective as the Kligman's formula for the treatment of melasma lesions. Next, please. So, yeah, I have already discussed it. You can go to the next slide, please. In fact, in our clinical practice, we know that Kligman's formula is an irritant formula. Usually, if you don't explain to patients that it can produce skin irritation, redness, and dryness of the skin, patients would come back or they would call you saying that they do not tolerate the Kligman's formula well. In the same study, cysteamine cream was compared with the Kligman's formula for its tolerability. And it was shown that cysteamine was much better tolerated in patients compared to the Kligman's formula. The light green area in these columns present the patients who had no side effects. And it represented 92% of patients in the cysteamine group. But in fact, 96% of patients in the Kligman's formula group showed at least some degrees of irritation, for example, burning and dryness. So cysteamine was much better tolerated compared to the Kligman's formula. Next, please. Next slide, please. Thank you. In another study, cysteamine efficacy was compared to tranexamic acid mesotherapy. I don't know if you use this treatment for your patients. This is something that I have already used very frequently for my patients. I know that tranexamic mesotherapy is one of the effective treatments against melasma. The problem is that you cannot ask your patient to come forever to your clinic to have, for example, monthly injections of tranexamic acid. After some injections, some sessions, patients would like to get rid of their melasma lesions and not to come back anymore. This is one of the weak points of such types of treatments. But regarding the efficacy, we know that tranexamic acid mesotherapy is one of the most effective treatments. In this study, two groups of patients were treated either with tranexamic acid mesotherapy or with the application of cysteamine cream at night for 15 minutes daily. Next, please. It was shown that after 8 weeks of treatment, we had no difference between tranexamic acid mesotherapy and Cispera. When I say Cispera, I mean cysteamine cream. Both these agents were effective for reducing the color of melasma lesions and the surface area of these lesions. In fact, modified Massis score had reduced in both of them. And after 16 weeks of treatment, there was no statistically significant difference between these two treatments. So again, we can say that a topical agent, cysteamine, is as effective as an injectable treatment, which is tranexamic acid injections for the treatment of melasma. Next, please. Regarding the tolerability of cysteamine compared to tranexamic acid, in fact, we see the same as what we had seen with the Kligman's formula. We know that with the injection of tranexamic acid, first of all, we have pain. So patients do not like that very much. And after that, we can have redness, we can have burning sensation, and the patient usually have some marks on their skin. So they cannot rapidly go to work. And all these limit the use of tranexamic acid, while none of these problems exist with cysteamine applications. Next slide, please. Next slide, please. So how should we use cysteamine? As I already explained, cysteamine is not a cream that you apply, that the patient applies and, for example, sleeps with it. It is used as a mask. The patient applies cysteamine on her skin, let it there for 15 minutes only, and then wash it away. An important point regarding cysteamine use is that usually the patients should not wash their faces before the application of cysteamine. Why? Because if the patient washes her face, she would remove some layer of the skin, and that would cause cysteamine to penetrate very rapidly into the skin, and that would cause some irritations. So what we recommend is that if the patient does not have any cosmetic products on her skin, she can apply the cream without washing her face. If she has some cosmetic products on her skin, she should wash the face anyhow, but in that case, she should wait for about 1 hour to apply cysteamine cream. Like this, the lipid layer of the skin is a little bit restored. Or sometimes I tell my patients, wash your face and put some moisturizers before application of cysteamine cream. After that 15 minutes of application, the face is washed by a soap, for example, a simple soap, and a moisturizer is applied. This is to be continued for several months usually. The first results are seen after a few weeks of application, like any other depigmenting agent. Usually we have gone to 3 to 4 months of application, but there is absolutely no limits for the daily applications. You can go to 5 months, 6 months, or even more. As soon as you have the optimal results in that patient, for example, melasma lesions are gone away, you don't need to continue it daily. You can, but you don't need that. In that case, you can shift to the maintenance treatment using cysteamine cream only twice weekly with the same protocol. Next, please. These are some cases treated with cysteamine cream. The before treatment image shows melasma lesions on the cheeks after 12 weeks of application of 15 minutes daily exposure. We can see the almost complete disappearance of melasma lesions. Next, please. This is another patient. Already after 8 weeks of application, we see that melasma lesions are gone away, and the skin seems much whiter than before. So the complexion has become lighter. I think this is something which is interesting maybe in your country. People would probably search for agents that lighten up the skin. So this is one of the indications of cysteamine treatment. Next, please. Another patient with post-inflammatory hyperpigmentation, acne-induced hyperpigmentation. After 8 weeks of application, the lesions are completely gone away. Next, please. Another patient with post-inflammatory hyperpigmentation. This is a high phototype. Usually, we are a little bit afraid of depigmenting agents to be used on higher phototypes, but we can easily use cysteamine on any phototype. That is the advantage of cysteamine over many other depigmenting compounds. This is another patient who was exposed to sunlight for many years because of her job. And she used cysteamine cream for several weeks. And when she came back to me, she told me not only hyperpigmented lesions are gone away, people tell me that I'm much younger. And we can appreciate that in this image. She was right. When we look at her, here we say that she has several years less after using cysteamine cream. She told us, why don't you call this cream an anti-wrinkle agent? So what that what had happened was that very probably the signs of photoaging had gone away using cysteamine cream in this patient. Next, please. These are some sporadic cases treated with cysteamine. One of them, which is important on the up right area, is lip depigmentation. We know that lips are very resistant to depigmenting agents. The reason is that there is no hair follicles on the lips, and usually depigmenting agents need hair follicles to penetrate into the skin. This patient had used many different depigmenting agents and modalities for the treatment of his lips. He had already used hydroquinone, trichloroacetic acid peelings, tretinoin, Kligman's formula, and even a laser for the treatment of this hyperpigmentation. All these were not successful, and he used cysteamine only for 19 days. And he found a very significant depigmenting activity of cysteamine on his lips. Only after 19 days of application, 15 minutes daily. Another case is macular amyloidosis, which is quite frequent in your regions, I believe. There was some improvement using cysteamine on macular amyloidosis. I don't believe that cysteamine causes the removal of the protein deposits of macular amyloidosis, but as you know, usually you have some post-inflammatory hyperpigmentation because of scratching these lesions. And I believe the improvement we see here is because of the improvement in post-inflammatory hyperpigmentation. Two other cases are hand hyperpigmentation because of chemotherapy and arm hyperpigmentation, forearm hyperpigmentation. We know that these two problems are very difficult to be treated by depigmenting agent, and cysteamine was very effective on both of them. Next, please. You can combine cysteamine cream nearly with any other modality for the treatment of hyperpigmentary disorders in your clinics. You can combine it with laser, you can combine it with microneedling, you can combine it with dermabrasion, with peelings, you can combine it with oral tranexamic acid, injectable tranexamic acid, you can combine it with Roaccutane treatment for acne. There is no problem with any of these treatments. It's compatible with all of them. The sole rule that you should respect is that if you use another treatment modality for your patients, wait until the irritating effect of that modality is subsided to begin cysteamine treatment. For example, if you have done laser on your patient's skin and the skin is red and irritated, just wait for a few days or even a few weeks until that redness is completely away and then begin cysteamine treatment. For Roaccutane, the same. Do not start cysteamine treatment at the same time of Roaccutane. Begin your Roaccutane, continue it for a few weeks or 1 or 2 months until skin dryness goes away a little bit, and then you can introduce cysteamine treatment to your patient. The same is true for microneedling and other modalities. Next, please. So these are some cases with the combination treatments. I go a little bit more rapidly on these cases. Next, please. Next slide, please. This is a case who was treated by Professor Marini in Italy. Could you go back to the case? It was an interesting case. Professor Marini in Trieste in Italy sent me that case. He had treated her with the combination of peelings, the combination of hydroquinone, azelaic acid, and cysteamine. So she had a very bad refractory melasma, and with these combination treatments, he managed to remove melasma lesions and give her a very lighter complexion at the same time. Next slide, please. So your first line treatment for the treatment of melasma is always topical treatment. Cysteamine can be used as the first line treatment if you do not like to use hydroquinone for any reason. If you have safety concerns with hydroquinone, if your patient has already used hydroquinone and she has not responded well to it, if she is sensitive to hydroquinone, if you'd like to use something newer than hydroquinone, as effective as hydroquinone and better tolerated and safer than hydroquinone, you can shift to cysteamine for any patient. The second line treatments for melasma usually are physical modalities. For example, lasers or microneedlings or injectables. As we see, cysteamine is as effective as injectables such as tranexamic acid. So you can use cysteamine as a second line treatment or combine it with second line treatments. For example, if you are using lasers, after the erythema has subsided, you can begin cysteamine for your patient, or if you are using injectables, you can combine cysteamine at the same time with these agents. The third line treatment is usually oral treatment. If nothing works for your patient, usually you can use oral tranexamic acid 500 milligrams daily for several months. It is a very effective treatment. I do like it very much. I do it in my clinic. The sole thing is that after some months of use, we do not know what to do. Should we continue tranexamic acid orally for the whole life? I don't like to do that because it can produce thrombosis. And we have to stop it after some months of use. If we don't do anything, you will have a rebound or at least a recurrence of your melasma lesions. So you can combine cysteamine with tranexamic acid, and after stopping tranexamic acid, you can continue cysteamine. This is very important that cysteamine gives you the opportunity to have a maintenance therapy that you can use for a very long time. This is not possible, for example, with hydroquinone, because hydroquinone use can be associated with ochronosis if you use it too long. The same is true for Kligman, it's still worse than hydroquinone. Or tranexamic acid, it's the same. No depigmenting agent is very safe to be continued for the whole life. Cysteamine is a biological molecule. It exists in your skin, it exists in your blood, in human milk, everywhere. And we have not seen any side effects using cysteamine frequently during the week for many years. I have many patients using it since 2013 now, more than 7 years of application, and we have recognized no side effects. Some irritations has happened in some patients, but we have not had any important side effects with cysteamine. So cysteamine gives us the opportunity to have an agent to be used for a very long time. If you use your laser, your oral treatments, and after that, you would not like melasma lesions to come back, put your patients on cysteamine cream, and you can continue that. Next, please. So thank you very much. I was very happy to be able to introduce cysteamine as the first-line non-hydroquinone treatment for the treatment of hyperpigmentation. And I'm at your service if you have any questions regarding this treatment.
Thank you very much, Dr. Kasri, for the very complete presentation about how we use the cysteamine. Okay, now we will take a look at the question box. We have already some questions from the audience. I will read the questions. The first question is from Dr. Meta Vitari. Morning, Dr. Kasri. Should we use this on the face entire or just on the lesion? Could you please explain?
Very good question.
Okay.
You know, for any depigmenting agent, I use it always on the entire face. I never use any depigmenting agent only on the lesions. The problem is that if you use the depigmenting agent only on melasma lesions, it would anyhow go around those melasma lesions. You can never limit it exactly on the melasmas. And what happens is that it would lighten up a little bit around those lesions too. And that would cause some irregularity of pigmentation. You should note that when you use a depigmenting agent on the whole face, melasma lesions would respond much more rapidly than the normal skin to that depigmenting agent. That is why the contrast would reduce. The contrast between melasma lesions and the normal skin would reduce even if you apply the cream on the whole face. So don't be worried about applying the agents on the entire face. Do that and know that melasma lesions would disappear much more rapidly than the normal skin would lighten up.
Okay, thank you, Dr. Kasri. And then the next questions. Now, this is from Dr. Ubeta. Dr. Kasri, is there any rebound effect after stopping the cysteamine application totally? This is about
No
rebound effect.
rebound effects exist, but recurrence can exist. As with any depigmenting agent, as with any melanogenesis inhibitor, if you stop the application of cysteamine, melasma lesions would come back. But the advantage of cysteamine, as I have already mentioned, is that you can have a maintenance treatment with it. So you use it for some months, the lesions are gone away, then you go to twice weekly or 3 times weekly application of cysteamine, and as far as you continue cysteamine applications, lesions would not come back.
Okay, thank you. And then we come to the next question. This one from Dr. Ubeta also. Can cysteamine be used? Sorry. Can cysteamine be used after applying sunscreen to minimize irritation? Yeah, please, Dr. Kasri.
In fact, if you have applied, if I have understood the question well, if you have applied any sunscreens, you cannot apply cysteamine on the top of that sunscreen. Why? Because we do not know all the interactions which are possible. You should remove that sunscreen and then apply cysteamine creams. I'm not sure if I understood that well or not. Cysteamine is not an anti-inflammatory agent. It can cause irritation if you expose the skin too long, for example, to this agent. So you should not consider it as an anti-inflammatory treatment. Of course, it does not do that.
Okay, yeah, okay. Should clean first the sunscreen and then apply
Exactly.
cysteamine.
Right.
Okay. And then we have the next question. How is your recommendation to incorporate cysteamine with retinol or peeling agent? Could you please explain?
You can combine them. I already do that very often. The general rule that I already explained applies again. It means don't begin 2 agents at the same time. Don't begin peeling and cysteamine at the same time. For example, begin your cysteamine if you'd like. Continue it for some weeks. You are sure that no dryness or redness exists anymore in your patient, then you can introduce your peelings. Or the opposite, begin your peelings, after some sessions, no redness exists anymore, or your peelings are finished. You do not have any dryness or skin exfoliation, and then you introduce cysteamine. Never use 2 irritants at the same time.
Okay, wait. Now, okay, that's about peeling. About another questions. Now, this one is from Dr. Megawati. Is there any adverse reaction? Sorry, wait. Is there any adverse reaction of cysteamine in long-term use? Okay,
We have
please.
not recognized any. The sole adverse reaction that I have seen in patients has been in the first weeks of application, and that is irritation. Usually it happens if the patient washes her face and just after washing applies cysteamine. That can cause some irritation because of the very rapid absorption of cysteamine in that case. Or patients who do not respect that 15 minutes application. They go for hours of application or the whole night application. If they do that after several weeks of application, nothing would happen. In fact, if they have already done 15 minutes applications for 6 weeks or 8 weeks, their skin becomes used to cysteamine treatment and they can begin to apply it more, some hours or even the whole night. The problem is the very first weeks of application. If they apply too long, usually they can have some degrees of irritation. Nothing bad would really happen. They become red or the skin becomes dry and it would be a little bit irritated. In that case, you stop the treatment, you moisturize the skin, or at the worst case, you can give some hydrocortisone treatments for a few days, and again, you begin systemic treatment.
Okay. Okay. And then we come to the next question. A doctor asks, when is the advised time to use cysteamine? Is it in the morning or evening?
I rather like to use it in the evening. Why? Because when the patient goes to sleep and in the morning she wakes up, she looks into the mirror, usually they see the effect. I like that wow effect after sleeping. Um, and usually they recognize better the effect of system when they wake up in the morning. I can't explain that very well, but this is what they usually say. Some of my American colleagues use it in the morning because they find it to be more practical. They say, we know that our patient does not have any cosmetic products usually on their faces in the morning, and just we tell them before taking your shower, apply cysteamine cream for 15 minutes and then take your shower. It's of course more practical and there is no problem with that.
Okay. Yeah. So we've got another question again. Now this one is from Dr. Melissa. Dr. Kasre, is it safe to give cysteamine therapy for pregnant women or breastfeeding women? Please.
We do not recommend to do that. The sole reason is that if something happens to a baby, as a doctor, you can never prove that it was not because of your treatment. So, not histamine, no hydroquinone, no azelaic acid, no depigmenting agents, because it's for the treatment of a cosmetic situation. You do not have to expose yourself to any legal problems because you have treated the patient with a safe depigmenting agent that you cannot prove has not done anything bad to the baby.
Okay. Yeah. And then the next question, if there is uneven skin tone, that means hypopigmentation problem in some areas, what is the best thing or best management therapy that we can do for the patient, please?
It depends. Of course, it depends what is the nature of those hypopigmentations. If the nature is hypopigmentation induced by corticotropy, cysteamine would be the best, I would say, because it really does something for the removal of those hypopigmentations. If you are in front of vitiligo, I don't recommend to use any depigmenting agents, and cysteamine is not an exception. If you are in front of pityriasis alba, for example, the treatment would be some emollients together with protopic treatment, and then when they are removed, you can go for the treatment of your hyperpigmentation.
Okay. Sorry, Dr. Kasri. Questions still related to another question about hypopigmentation in some areas. What's the best thing we can do after applying cysteamine? Maybe she is asking after applying cysteamine, is there any possibilities that comes hypopigmentation?
We have never seen that.
Okay.
We have never seen any hypopigmentation or vitiligo-like lesions associated with cysteamine use.
Okay, thank you. And then the next question, this one is from Dr. Jocelyn. What agent that we can mix with cysteamine, especially for sensitive skin patient? So what kind of agent that we can mix with cysteamine?
Usually, I don't mix anything with cysteamine. If you have a sensitive skin, for example, if you're in front of a patient with atopic dermatitis, with a very dry skin, I would recommend to moisturize the skin very often. If there are erythemas or signs of inflammation already, do the treatment of atopic dermatitis with corticoid treatment or protopic treatment. And when the skin has become normal, you can go to the treatment of hyperpigmentation lesions.
Okay, yeah. And then the next question. This one is from Dr. which one is this to apply? Maya Hanif, to Dr. Kasre, for hyperpigmentation post-inflammation, we use just on the spot post-acne or in the whole face. I think you have
Always
just
on the
mentioned about
whole
this,
face.
but maybe,
Yeah,
okay.
always on the whole
So
face.
it's
I
better to
never
apply
leave.
the whole face.
Yeah, exactly. The same as
Okay.
melasma lesions. Apply everywhere. Don't be afraid. Only hyperpigmented lesions would respond.
Okay. Okay. Yeah. A doctor asked, is it safe to use or apply histamine twice a day? I think this is
It would be too
too
much.
much.
It
Yeah,
would
too
be too
much.
much.
Okay.
You should not go towards too
Mhm.
frequent applications. You must not go towards longer applications. Know that even 5 minutes application of cysteamine per day is quite effective. What we have found is that cysteamine is very probably recognized by the skin cells as a self molecule. They absorb it very rapidly. And you do not need long exposure time or too frequent applications for it to become effective. This is the tendency of some patients to increase the exposure time to cysteamine. You should tell them that they must not do that. Sometimes patients come to me and tell me, I tried to put cysteamine for 2 hours instead of 15 minutes because I thought it would be more effective, and now I have some redness. I tell them, when it is written on the box of a cake that you should put it in the oven only for 10 minutes. Do you put it for 2 hours for it to become more delicious? It's not the case. So respect those 15 minutes and once daily applications.
Okay. Thank you. And we have got another question. This one is from Dr. Christina. Do we need to apply serum or night cream? For example, anti-aging serum and cream after using the cysteamine?
It is always indicated to moisturize the skin after the application of cysteamine cream. So when you wash the cream away after 15 minutes of application, it is always recommended to use a simple moisturizing cream. And if the patient has dry skin, she can do that several times daily, 2, 3 times daily, to apply her moisturizing cream. Just avoid other treatments at the same time. Do not use medical treatments begun at the same time with cysteamine, as I have already mentioned.
Okay. Thank you. We have another question again from Dr. Arumsari. Can cysteamine used to reduce freckles? Please, Dr. Kesri.
We do not have any clinical studies showing that, but I have had sporadic cases with freckles and even with lentigos. I personally never prescribed it for lentigos because I didn't think that it could be effective for lentigos. But I have had some patients who tried to apply them, for example, on their hand lentigos, and they found that it is effective. I don't have any data regarding freckles or lentigos to show you, but from those sporadic cases, apparently there is something that happens with cysteamine. I cannot explain you why, because I know that usually depigmenting agents should not be effective on lentigos, but for some unknown reason, it does something.
Okay, thank you. Another question again. This one is from Dr. Megawati. Can we use the cysteamine in other parts of the body besides the face, and how do we use it for the body?
You can use cysteamine everywhere on the body. There is no problem with that. We can even treat the intimate areas for the treatment of hyperpigmentation of these areas. Usually, I would tell patients to begin with shorter exposure time, such as 5 minutes, and then increase it little by little to 10 and 15 minutes. But there is no problem for using cysteamine on any other parts of the body other than the face.
Okay, can we combine with the pigmentation? Okay, okay. I think this is enough for the question because I think we are running out of time. Still another question. if we got patient who is resistant for Klickman formula, when we want to give the histamine, do we have to do tapering off, or we directly give the histamine for the patient? What do you
What I have
suggest?
always done is I stop Pigment's formula and then I begin cysteamine cream. Something which is important to explain to patients is that during the first weeks, maybe melasma lesions would come back a little. Why? Because it takes time for cysteamine to begin to work. Like any other depigmenting agents, it would take 3 to 4 weeks for it to begin to work. And when you stop Pigment's formula, you can have some recurrence of those lesions. You should explain that to your patient and tell them to be patient, as they are called, patients. So they have to be patient for that. And after some weeks of application, histamine would begin to work and lesions would lighten up again.
Okay, thank you very much, Dr. Kasre. I think because we're running out of time, thank you very much for all your presentation or your sharing about the knowledge about how we use the histamine to manage for hyperpigmentation. And for the closing, could you please give some take-home message, what to notice for the patient with hyperpigmentation for these participants, all doctors? Please, Dr. Kasre.
So first of all, thank you very much for giving me the opportunity to have this presentation. It was a great pleasure. The take-home message is that now you have a new agent for the treatment of hyperpigmentary disorders, which is as effective as hydroquinone, probably more effective than the Klickman's formula, or at least as effective as that. It can be used for very long times. It has not been associated with any side effects, at least up to now. It's a biological molecule. It can even be taken orally for the treatment of some other diseases. For the treatment of cystinosis, for example, it has been taken orally. It's a quite safe agent. So consider the treatment with histamine cream for your patients for hyperpigmentation as a first-line non-hydroquinone treatment, as an associative treatment with other modalities, or as a maintenance treatment for long-term use.
Okay, thank you very much. Once again, we will thank you to Dr. Behrouz Kasre for all your sharing about this system in works for hyperpigmentation. And stay safe, stay healthy, Dr. Kasre. Success for you. Yeah, thank you very much for this very interesting session.
Thank you
Okay,
very much. Thanks to you.
for all participants, this is the end of the session one for about hyperpigmentation. And now, after this, we will come to for a break time. You can have lunch break time, and then we will be back again at 2 p.m. in Jakarta time. Okay, so after this, we can have break. Okay, thank you everybody. Thank you, Dr. Behrouz Kasre.
Thank
Yeah,
you. Thank you.
stay
Goodbye.
safe.
Thank you.